Thank you very much, Sangeet. Sangeet is the engine of this program, actually. He and his team are managing everything from registration to sending out invitation, managing WhatsApp group, and so on and so forth. So at the very outset, I would like to thank you so much, Sangeet and the team. Hello, everyone. A very good afternoon. I would like to wish everyone a very happy new year. I'm immensely excited and grateful for being able to start this year, 2024, with this much awaited course on palliative care for our healthcare professionals in Bhutan. On this very first session, we are joined by the Honorable President of the University of Medical Sciences of Bhutan, Dr. K.P. Tsring. Thank you very much, sir, for agreeing to attend this opening session. Your presence here actually means a lot to me and to everyone here. Just to let Sir and the participants know about how we came up with this course. This course has materialized only because of the invaluable support from the two international organizations. Australasian Palliative Link International, in short, it is called APPLY, APLI, and Pallium India. APPLY is an Australian-based NGO which aims to relieve suffering arising from advanced illnesses in the low and middle-income countries in the Asia-Pacific region through education, advocacy, and service development. Pallium India is another NGO based in Trivandrum, Kerala in India, and that's where I received the first week hands-on, 6 weeks hands-on training on palliative care in 2016. Besides providing quality pain relief and palliative care, Pallium India also provides palliative care education to healthcare professionals and the general public, as well as facilitates development of palliative care services across India. APPLY and Pallium India have together developed several palliative care services in India, and today Bhutan is fortunate to be collaborating with them. Just to inform Sir and the participants here, we have 8 faculty members for this course, both from Australia and India, with diverse backgrounds. They are doctors, nurses, nurse practitioners, pharmacists, and counselors, all experts in palliative care with vast experiences. And these individuals are super busy people, but they are offering us completely free and voluntary service. So I would really like to extend a heartfelt gratitude to the team. Thank you very much, everyone. Also, just to let Sir know that this is a 6-week course conducted every Thursday for 1.5 hours, starting from 3:30 p.m. to 3:30 to 5 p.m. Today is the first session from 11th January, and it goes till 15th of February. Today, on the first session, we will be doing Introduction to Palliative Care, and next week will be Pain and its Management. On the third week, we will be doing management of other symptoms besides pain, like dyspnea, nausea, and vomiting, and so on and so forth. On week 4, we will be doing communication skills and breaking bad news. And week 5 will be on terminal care and pharmacy issues. And the last week will be on community-based care and nursing issues. Many of the sessions from next week onwards will also include case presentations from our experience from Bhutan. And we have more than 150 participants registered, and they include doctors, including specialists, nurses, pharmacists, physiotherapists, and physiotechnicians. So with that, I would now like to request our President, Sir, to say a few words to the audience here. So over to you, Lesser.
I think
Can you hear me now?
Yeah.
Okay. Good afternoon to everyone. It is with great pleasure and commitment to the well-being of individuals and families facing life-limiting illnesses that I welcome you all to this online certificate course on palliative care. I would like to express my deep gratitude to Pallium India and Australasian Palliative Link International, who developed this course. And in particularly this course has been tailor-made for the Bhutanese health professionals. I really thank the organizations for their initiatives for palliative care in Bhutan. Palliative care is a holistic approach that extends beyond the management of symptoms to address the physical, psychosocial, emotional, and spiritual needs of patients and their families. In the pursuit of enhancing the quality of life for these navigating life-limiting illnesses, this course aims to empower you with a profound understanding of palliative care principles. I believe that through these engaging modules and interactive sessions, I'm sure it will equip you with the knowledge and skills necessary to identify and meet the unique needs of patients and families during challenging times. I believe that this course will not only deepen your comprehension of palliative care, but will also foster compassionate and empathetic care in your daily practice. I thank all those who have joined us in this journey towards better care, greater understanding, and enhanced support for those in need. I can see the dedication and commitment in the Bhutanese health professionals by seeing the overwhelming attendance on the online course, which usually is not that popular. But I see, as Dara mentioned, 150 plus attendance on online course. I think that shows the compassionate feeling that health professionals of Bhutan have for this issue. So your dedication to advancing palliative care in Bhutan is not only admirable, but also crucial for creating a more compassionate and informed care landscape. So I thank you for your commitment to excellence in healthcare, and we look forward to embarking on this meaningful learning experience together. I wish you all the best, and I would like to thank all the resource persons, and I would like to thank Tara for connecting these organizations and bringing this collaboration to the university, and we are very grateful for that, and we are happy to have been collaborating with these famous organizations to improve palliative care in Bhutan. Thank you very much once again, and all the best.
Thank you very much, sir. As always, I'm motivated further to work hard, particularly on palliative care. And I'm sure everyone here is motivated to make the best out of this opportunity. And with that, thank you once again, sir. And please feel free to leave as and when you would wish to, sir. And now we will start with our first session, Introduction to Palliative Care. The session will be presented by Dr. Odette and Smriti Rana. Dr. Odette is the Medical Director at the Specialist Palliative Care Service North. So Dr. Odette is the Medical Director at the Specialist Palliative Care Service North, Tasmanian Health Service. Odette has worked in all sectors of palliative care, including community, hospice, and consultative services. Odette has held several leadership roles in palliative care in Australia and New Zealand, including as a past president of Australia-New Zealand Society of Palliative Medicine. And our second presenter today is Smriti Rana, who is the head of strategic programs and partnership at Pallium India. Smriti has almost 2 decades of experience in palliative care with deep personal ties to her work. At Pallium India, Smriti aids in integrating palliative care into the Indian health system, focusing on increasing safe access to adequate pain relief and patient support across the continuum of care. She is the India Advocacy Focal Point for the International Association of Hospice and Palliative Care, and is the Vice Chair of the International Drug Policy Consortium. Internationally, Smriti's work also focuses on equitable access to pain relief and decolonizing healthcare. Following the presentation will be the question-answer session, and I would really like to encourage the participants to ask questions using the chat function and also by unmuting yourself. Thank you, and over to you, Odette and Smriti. Thank you very much.
Good afternoon, everybody. I hope you can hear me. All good? Thank you. It is such an honor to be part of this online course, and I thank you very much for the opportunity and congratulate you, Tara, and all your team for getting this to happen. And it's a great pleasure to be working again with our colleagues in Pallium India as well. So I have the honor of talking to you about palliative care, and I think any doctor who works in this field loves to talk about palliative care and what it means. So I'm thrilled to be able to give you my version of what palliative care means to me, I suppose. And hopefully that will be of some value for you. Sangeet, could we have the first slide, please? Thank you.
Is it visible, ma'am?
That's perfect. Thank you so much. Okay, can we have the next slide, please? So my talk today will be, I guess, around three main areas, although I think I've tagged on a fourth area as I tend to do. So I want to talk about the definition of palliative care, a brief history, maybe, and some of the global story, some context, and then start to sort of tease out with you what it means to introduce palliative care to patients. Who is the palliative care patient? When do we start to talk about palliative care and provide palliative care, and how do we best do that? And then in the final few slides, I thought I'd add some information and maybe some resources that could be useful for you, resources developed by WHO in recent years to help at a kind of national level to think about how to develop palliative care at the country level. So next slide, please. In 2020, the definition of palliative care was revised. It built on the pre-existing definition from WHO that has been around for a good 50 odd years. So some of it's much the same, and there's perhaps one area that is of new focus. So essentially, palliative care is active. And I like to emphasize that because sometimes doctors here might say, we're going to stop active management and refer to palliative care. But palliative care in itself is active, it's holistic. These words can sometimes lose their meaning because we say them, but holistic means the whole person. So it's person-centered, and we have to think, well, what is a person? What do we understand by a person? And it's not just the physical body, but it's their social world, their relationships with others, their community, their role in their community and their family, their spiritual life, so many dimensions. So palliative care is very ambitious and tries to really think about the whole person, the person with illness, not just the illness. across all ages. So pediatric patients also in need should be able to access palliative care. And that's certainly a big gap internationally at this stage, right through to the very elderly. And the key focus now in palliative for who should be getting access to palliative care, it's those people with serious health-related suffering due to severe illness, and with still a particular focus of those patients who are coming towards the end of their life. So we're not talking about palliative care for just cancer patients. It's not a diagnosis-dependent area of treatment or care. And it's also not just about the patients who are really at the end of their life. It can be of value for patients who are earlier in their disease. And the other big focus, really the crux of it all, is we focus on trying to improve the patient's quality of life. And also recognize that patients usually exist within a family group, within a community, and we try and incorporate the care of the family, because if the patient's suffering, the family suffers. If the family's suffering, the patient suffers. And so often we hear patients saying they don't want to be a burden on their families, and we try and really help patients and families to have the best possible quality of life in despite their illness almost. One of the key quotes that we use often in palliative care is we try and put life into days rather than days into life. Much of our medical care is about trying to improve survival, improve longevity. I guess palliative care, that's wonderful when that's possible, but for us, the main focus is on, well, what is the quality of that life? Next slide, please. So this concept of serious health-related suffering means suffering that's associated with illness or injury, which cannot be relieved without professional intervention. And it's suffering in physical, social, spiritual, or emotional dimensions. And you can see this man, this was a picture taken from a northern Indian radiotherapy center. He has a large left humeral bone metastases, and he's having radiotherapy. You can see from his posture that there's physical suffering. You can see from the concern in his wife's face that there's probably social and emotional suffering for her as the caregiver, as well as for him as the patient. You can see perhaps that he hasn't got much support to that arm, that maybe the arm could be better supported. But to me, this, and the look of sort of entreaty in his eyes, looking to the doctor for some relief of that suffering. Next slide, please. And the definition goes on to further tease out what palliative care tries to do. So we try to do a really comprehensive assessment of the patient and manage their physical issues. So that means really doing a good history and really being interested in the detail of their symptoms, but also their psychological, spiritual, and social needs. We understand that by facilitating good communication, we help patients to make good decisions about their medical treatment, and we try and involve patients and families in decision making and give them the information they need to make good decisions. So that involves, an ability to communicate difficult news sometimes, to do it sensitively and carefully and at a pace and in a way that is acceptable to the patient and their family, which is not always easy in our busy medical lives. And we also, as I've mentioned, that palliative care is applicable throughout the course of illness according to the patient's needs. So that's for definitions. Next slide, please. I undertook a study asking doctors in India and Australia how they recognize and respond to suffering. And I'll share this quote from one of the doctors because it points to the importance of being willing to see suffering, but also the importance of trying not to be overwhelmed by it. So it's just a reminder that by engaging with the suffering of our patients, we are impacted as healthcare professionals. And so a core component of being willing to do palliative care for our patients is also looking out for ourselves and developing the skills and the strategies to be able to work with patients who are suffering without becoming overwhelmed. So she says this doctor used to go to remote areas of India and spend 2 or 3 weeks there doing clinics. And she said initially she's just overwhelmed by the extent of suffering that she's confronted with when she goes to these remote areas. But then she says, then she starts to kind of break it down and I guess applies her skills and her knowledge and her development as a palliative care practitioner and starts to identify different elements of the suffering that she can then help the patient with. And once she does that, then she's able to sort of find some more meaning in the work. I guess a lot of doctors and healthcare professionals find meaning when we're able to cure a patient. And that often doesn't happen in palliative care, but we can find meaning in other ways in our work. Next slide, please. So looking at Bhutan, there is a website from the International Association of Hospice and Palliative Care that contains this global database of serious health-related suffering. On the website, you can find the methodology of how this is actually calculated, and we don't have time, we don't need to go into that now. But you can search by country, or you can search by disease. So I looked up what's the rate of serious health-related suffering in Bhutan, and according to this website, it's estimated at 5,000 people in Bhutan have serious health-related suffering. And I think Tara could talk to us about her study, perhaps in a discussion where you looked at the suffering that the patients in your palliative care service in Bhutan experienced. And I'd love you to comment on this later when we have that discussion, whether you think this is reflective of what you saw. But the website also shows what are the illnesses that are most contributing to that health-related suffering. And in Bhutan, it seems that HIV, cancer, and cerebrovascular disease are the major the illnesses that cause the majority of suffering. And you can also compare your country with other countries of similar income groups, other countries in your region, and then other countries around the world. So you may find that interesting to have a look at. Next slide, please. So now I just want to talk about the history, a brief history of palliative care. I'm just going to keep an eye on the time. So I think throughout the ages, people who have advanced illness and who are dying have generally been cared for by their families in their own homes. For those that didn't have a family, who maybe were destitute or for other reasons, there were often religious or charitable organizations that provided care for those patients who were dying. In the 1900s, as medicine, modern Western medicine developed, there tended to be a sort of side product, if you like, or we were developing new technologies and new therapeutics, and unfortunately, we started to neglect the patients who were not curable and who were dying. And this really came to the foreground and was recognized and addressed by people in different countries, more or less around the same time in the 1950s, 1960s. And one of the key pioneers was this lady, Dame Cecily Saunders. And she opened the first so-called modern hospice in England, in the south of London in 1967. It's called St. Christopher's Hospice, and it still exists there today. And it's been a major teaching centre for many, many years. And then gradually from the 60s throughout the second half of the 1900s, more and more countries came on board with developing palliative care as an area of medical and healthcare practice. I like this quote from Dame Cicely about you matter because you are you, and you matter until the last moment of your life. And a lot of her writing really emphasizes the importance of the individual and the person with illness. Next slide, please. So at various times, some research groups have looked at the global levels of palliative care development, and I think this is the most recent one that the group David Clark and colleagues have published. It's from data collected in 2017. And they categorize levels of development into 6 levels. And in this particular study, they were able to include data from 198 countries, including Bhutan. And they found that 24% of countries had, at that time, no known activity in terms of the development of palliative care. But they were also able to show that development was occurring, but that huge gaps in development existed. And their study and other studies looking at the quality of death and dying across, the world, there've been 3 studies that have been conducted by I always forget the Economic Development Unit, or the EIU, I forget the name, have usually involve about 80 or 90 countries, and they try and measure the level of development of palliative care according to some KPIs that they have identified. But generally, all these studies show that the more economically affluent countries tend to be providing more palliative care than less developed or less affluent countries, which I think is interesting because we talk about palliative care as being low tech, high touch. And so it shouldn't necessarily equate to resourcing, really. So I always think that's interesting that that nevertheless there is this close alignment between more economically affluent countries and the development of palliative care. Next slide, please. So for Bhutan, in 2017, you were still in that early stage, category 1. But I think again, Tara, you and others in the group might be able to discuss this later, but I think there has been some significant development since that study was done. So for example, I think in 2018, a home-based palliative care service was initiated at one of the major hospitals, and also dedicated palliative care beds in an oncology ward. And then in 2020, Her Royal Highness launched a palliative care service package at the National Traditional Medicine Hospital, which is a lovely initiative. And that linking of traditional medicine with Western medicine really offers great scope for how palliative care would be practiced in Bhutan, I'm sure. Next slide, please. But this Lancet Commission study, however, talks about the lack of access to palliative care globally as an abyss. I think you're familiar with that word of abyss, a huge gaping gap, and something that really challenges us all to try to to make a difference in this, because it means that there are many people in this world who are suffering unnecessarily with some extra skills and access to medicines. Their suffering could be significantly relieved. Next slide, please. And in that same Lancet Commission article, they talk about the essential palliative care package, which consists of essential medicines. And these are medicines listed in the WHO Essential Medicines List for adults and children. So they're easily accessible on the WHO website. Plus essential equipment, for example, IDCs for urinary retention, some pressure area sort of mattresses or similar incontinence equipment, and thirdly, essential human resources. So trained staff, healthcare providers who understand some principles of palliative care, not necessarily specialists, which is why it's so wonderful to see so many of you from so many diverse specialty areas participating in this course. And can you, next slide, please? I think we want to emphasize here the importance of access to oral morphine and also injectable morphine, and the importance of training. And these are the core components. Thank you. Next slide. So then, next stage of that I thought I'd talk about is really how do we bring palliative care into our existing health services? Next slide, please. So first, maybe who should be providing palliative care? And the simple answer is we all should be providing palliative care, whether we're working in primary health services, whether we're specialist oncologists or cardiologists or respiratory physicians, or maybe one or two will go the way that Tara did and develop a real specialty expertise in palliative care. And those people are the ones who will probably help to develop the expertise amongst the wider medical community. But patients, certainly not every patient who has symptoms from cancer or other illnesses or is approaching the end of life needs a specialist palliative care provider. Most clinicians can develop the skills to provide good communication, good symptom control, and good end-of-life care. And it's a small proportion who may need more expertise. So we're all in this together. And we would also add that the community is also part of this. We have a lot of volunteers who help us with supporting patients, particularly patients at home. And dying is not primarily a medical thing, but dying is part of our human condition. And we're all involved in the care of the dying. Next slide, please. So at this point, I thought I'd introduce you to a patient I helped to look after because she wrote a reflection about what palliative care meant for her during her illness. So I thought I'd share some of her reflections as we go through. So JW was a young 48-year-old woman, single woman, but lived with her brother and her brother's 3 children and had an active work life and an active life in general. But she developed a DVT and abdominal bloating, and that led to a diagnosis of metastatic ovarian cancer. She said she had many plans, but interestingly, she said her diagnosis was a type of release for her. She was determined to take this on and change her life for the better. I think that's interesting. We all, we try not to assume in palliative care. We try to always find out, well, what does this mean for the patient? Not sort of, oh, it must be terrible, how awful. This patient was somehow able to really take this devastating event and turn it into something quite positive in a sense for her. So next slide. So she said, as it became clear that my cancer wasn't responding, her clinical nurse consultant gently broached the topic of palliative care. She was very honest and said, I'd like to say I handled this with the grace that I had my diagnosis and treatments, but I didn't. I had thoughts like, they're giving up on me. I'm being pushed away. I'm not finished fighting this yet. I felt angry as I thought I was being abandoned. I could not have been more wrong. I knew very little about palliative care. So we find that in Australia as not an uncommon reaction. And unfortunately, some doctors also think similarly that if they introduce palliative care, the patient will feel as if they're being abandoned, and they struggle too to involve palliative care because it has a strong connection to late stage disease, at least in the way it's developed in Australia. Perhaps in Bhutan, as it develops, you might be able to avoid that same problem and introduce palliative care in a much more normative, supportive way. So next slide, please. So these are some of the misconceptions that can develop around palliative care. And I think it's because while we do say palliative care should be available throughout the course of illness, we know that most commonly patients come to a palliative care service because their disease is incurable and they're starting to really face the prospect of dying. And so it still is obviously connected to the fear of dying, and most of us do struggle with that. And so palliative care does become sort of enmeshed with the concept of dying, or the prospect of dying. So there's a sense that maybe palliative care is a last resort, and therefore, you know, everything else has failed. I must be right at the end. That is a misconception. That it's inactive, that it's giving up, that it's not compatible with medical interventions, that my oncologist is no longer going to want to see me, that now I'm just going to palliative care. And also that best care is care that's of the, you know, disease focused rather than patient focused. So, and I think as doctors, certainly, we often are more comfortable dealing with the disease than we are with the patient with disease. Perhaps nurses don't suffer that same problem, but certainly doctors sometimes are more comfortable with the illness itself than the patient with the illness. Next slide, please. So this is a kind of model for thinking about how to involve or integrate palliative care, when to do it. And again, as you can see from the yellow part of the diagram, which represents the palliative care bit, you can have palliative care right at diagnosis, but generally it's a lower part of the whole care provision. In the earlier stages, or when the patient's having curative or life-prolonging treatment. Say this is in a cancer example, but the need for palliative care may increase along the trajectory of the illness, and such that by the end of the illness, the whole of the patient's care is palliative in focus. And remember too that families also often need or may need care after death, and part of a palliative care service is to provide bereavement care of some sort, and that's done in many different ways. Next slide, please. So in cancer, sometimes this is perhaps changing now, but it has been a bit easier to prognosticate. We generally can tell that once a disease is widely metastatic, a cancer disease, then it's the prognosis is probably more predictable, although with illnesses such as prostate cancer and breast cancer now, people are living longer and longer with metastatic disease. So that's changing, but that's kind of been the traditional trajectory of cancer. And so it's a little bit easier to then know when to perhaps involve a palliative care team. Whereas in other non-malignant illnesses, there may still be a big role for a palliative care service, but the timing of that, certainly around trajectory of illness and prognosis, can be more difficult. But if we go back to the needs and the serious health-related suffering, then that can be kind of more individualized. But I want to just make the point that palliative care is also often of great benefit for patients with non-malignant illnesses. Next slide, please. And that an integrated approach that allows shared care between specialist and non-specialist palliative care, primary care, and other specialist groups caring for the patient produces the best results for patients. Now, looking at what does palliative care actually do? So this study looked at a day in the life of the palliative care team working in a hospital. So we address social needs. We try and understand the person with illness, symptom control, care of the family, communication and shared decision-making, the care of the dying, very importantly, self-care and team support and coordination of care. So for JW, she had, next slide please, symptoms of ascites, abdominal pain, shortness of breath, leg edema and fatigue. She had complications of her treatment that we tried to help with some decision-making. Psychosocial issues were not a big component of her suffering. She was well supported. We were able to help with her decision-making regarding future therapies and help her decide where she wanted to have her end-of-life care and help to coordinate that care. Next slide. So she said she was surprised that the hospital's gynae-oncology team includes palliative care. So this was an unusual model, and I don't know if it exists elsewhere in Australia, but this was in a Sydney hospital where the gynae-oncology team actually had palliative care specialist on their team as a core team member rather than as a consult service, which allowed for a very lovely integration of palliative and oncology management. And she found that it was very reassuring that the care she was used to from her gynae team was able to continue right through to her palliative stage. Next slide, please. I won't spend time on this because I'm running a little bit over time, but people have been grappling with what is the best way to integrate palliative care into a patient's care. And for many years, there's quite a big literature on this. And I think for me, this has to be very much a locally grappled with and decided issue, because the integration of a palliative care specialty expertise will depend a lot on what's the existing team's capacity to provide that care themselves. And that's going to vary a lot from place to place. But in the model here, the authors were arguing that palliative care should be a routine part of the care of the patient with cancer rather than something broken up into different clinics that they felt would just confuse and cause a loss of integration. Next slide, please. So a doctor from India, Naveen Salins, did a systematic review of how the views of oncologists and hematologists impact on palliative care referral. And he found a number of key barriers which tended to cause delays or hesitations in involving palliative care and clinical care. Some issues around the fear of abandoning the patient, the fear of loss of the therapeutic alliance, some issues around hierarchical issues and power relationships, that the referrer may not trust the palliative care services expertise because they're not used to working together. Sometimes just the very method of making a referral can be quite a barrier in itself. The palliative care services need their statistics and their data and their referral forms, but sometimes for the referrer that can be quite a barrier to actually do that referral. And then the cost benefit Involving another team increases the complexity of coordination of care, and sometimes referrers are not sure whether that outweighs, that extra cost is outweighed by the potential benefit for involving another team. Next slide, please. So from our experience, when I worked at a cancer centre and some other experience in the literature, I think we as palliative care services need to really develop strategies to increase our availability to provide palliative care where and when it's needed. So one of the key strategies we did was to have more palliative care clinics in the outpatient clinic area at our cancer centre. And that meant that we were working much more alongside our oncology colleagues and were very accessible to them. If they wanted to get some advice on pain management or to involve us in the care of a patient, we could come and meet the patient with them. And that reassured the patient that we were working together. And there were, the issue of non-abandonment was addressed that way. Also, looking at opportunities to do collaborative research, and that helped us to get more integrated with our hematology oncology team. And likewise with the specialist team for adolescent and young adults with cancer, we were able to incorporate palliative care expertise into that team. And then I mentioned that model of the gynae oncology team in Sydney. And then others have tried to look at actually developing some consensus referral guidelines. And there's a reference to that there from Gardner. Next slide, please. So some of the context-specific issues may be around the cultural acceptability of death and dying, how well a culture or a society is able to sort of deal with death and dying. If there's a high level of denial of death, then that tends to have an impact on the involvement of palliative care services. Other context-specific aspects include what are the existing services and practices, and therefore what is the need for palliative care in different contexts? What resources are available? Are there champions who can really help to integrate and raise awareness of palliative care and do the education? Maybe the availability of telehealth will also impact on how palliative care is integrated, and the skills and competence and confidence of the primary treating teams. So Jade, just a final mention from JW. She felt that palliative care did transform her quality of life, that it was holistic. She felt valued and well supported, able to have an impact on choosing her medications, and the collaborative process was really appreciated. And she felt that not facing her death alone was something that made a big difference for her. So I think time is starting to just get away from me, and we've got maybe 2 or 3 more minutes. Is that okay, Tara?
Yeah, should be okay. And Smriti will
All right.
have another 30 minutes. So yeah.
All right, I'm nearly there. I'll just make a couple of mentions of these international organizations. So if you could do the next slide. Maybe go on to the next one. And the next one. Yeah, there we are. If we go to the resources, thank you, Sangeet. So these are 2 resources that WHO put out in recent years. The first one is the Quality Health Services and Palliative Care practical resource that is designed to facilitate action on quality palliative care from the national level to the point of care. And that's really aimed at helping policymakers and service planners but also healthcare providers at different levels. And the second one that's useful from a national planning level and a sort of monitoring of development level is the actionable indicators for palliative care. And I encourage you to take a look at those. Next slide, please. The actionable indicators identifies 18 indicators and 14 of them for different levels of development in the country. Some of them, they're divided into core and strategic, and the strategic ones are the ones for countries such as Bhutan, I think, that are really at the very early initial stage of developing palliative care. And it's possible to kind of help to focus on where you need to develop at what stage of your development as you try and develop palliative care in Bhutan. And the next slide is that palliative care is now included in the WHO Universal Healthcare Compendium, and you can find that a useful resource as well. And then finally, some palliative care organisations that perhaps could be valuable for you. The International Association for Hospice and Palliative Care, the Worldwide Hospice Palliative Care Alliance, and the Asia Pacific Hospice Network. They're all very good sources of information and resources, education and training and so forth. And then I've also included the African one just to show that the first three are more perhaps regional and global, but also many of the continents are developing their own continent-wide palliative care associations. Now, I know there've been some questions coming up in the chat, and I thought maybe, Tara, I'd ask you whether you want those to be addressed at the end or whether we spend some time discussing them, but that's the end of the presentation. Thank you.
Thank you, Odette. And I think we will first listen to Smriti, and then many of the questions might get clarified. Otherwise, we will discuss after Smriti's presentation, if that's okay. Thank you very much, Odette.
Thank you.
And over to Smriti. Hi, Smriti.
Hello. Hi, Tara, and hello, everybody. Really delighted to see this group come together and be here for the first session. So Odette, of course, has covered everything quite comprehensively. I'm here to, just talk about palliative care more from a low and middle income country setting. And I'll give you a few examples also from India. And maybe you'll find that there is some similarity in our experiences as neighboring countries, and also some of the challenges that we have faced, which potentially Bhutan is going to also have to tackle as the palliative care, the services develop in the country. Tara, my connectivity may be a little bit shaky, so I'm going to turn my video off as I speak. And in case there's a problem, just please let me know. Yeah. Okay. So, thank you to Odette for actually making my life a lot simpler, because I don't need to go into too many details now. So very quickly, let me just also, talk about the fact that we need to really center the idea of palliative care and palliative care services in the overarching idea of what healthcare is. And one of the things we try to do is, in countries like ours, the need for palliative care is actually greater than what might be experienced in the West, simply because disease-specific treatment does not reach people in time or adequately, or sometimes it's just unaffordable. And therefore, in India, we have patients who don't have life-threatening conditions. They might have, they might have been in a road accident and with spinal cord trauma. We have children with congenital anomalies in our care. We have people with, conditions that are chronic 10 years sometimes. So the idea of palliative care in our country is quite often different different from what it is experienced in the care to the larger healthcare system, so that every aspect of healthcare has an element of palliative care. We have a long way to go there, but it is an aspiration. So in India in 2015, we actually ranked 145 amongst 195 countries.
Sorry, Smriti, you're breaking off sometimes, so I don't know.
Oh, is it quite bad?
Yeah, little bit. I just thought I will say now so that it will just go on.
Yes,
yeah.
Thank you.
Yeah.
Let me try switching connections, Tara. Just
No
give me
problem.
1 moment.
No problem.
Are you able to hear me better now?
Yes, it's better. Thank you.
Okay, thanks, Tara. So, so India's healthcare system ranked pretty poorly in 2015. We ranked behind Bhutan and our other regional neighbors. And this is we haven't seen much improvement in that regard. And I think Odette had referred to this study, the Lien Foundation study on the quality of death index. And they had commissioned the Economist Intelligence Unit to actually study these different countries. Unfortunately, I don't think Bhutan is mentioned here, but the quality of death was measured against various indices, everything from the infrastructure available to the training level of healthcare workers to access to medicines and so on and so forth. And in 2015, India ranked 67 out of 80 countries. And in 2021, we made a little bit of progress, 59 out of 81 countries. And if you look at this diagram, unfortunately, I can't zoom in, but majority of the countries in the lower half are low and middle income countries. And this speaks to the fact, I mean, I'll be talking about this a little bit later as well, but this is an ongoing exercise, and I think the Lien Foundation and the Economist Intelligence Unit will be coming back to review this in a couple of years. Now, here's a National Crime Records Bureau statistic. In India, in 2014, approximately 26,426 people chose to end their lives through suicide. And these were all people living with various life-limiting and life-threatening conditions. This is the second highest cause for suicide in India in 2014. Unfortunately, that trend has remained consistent. And in 2021, we reached an all-time high. And again, people living with chronic and advanced illnesses came in the, as the second reason why people chose to end their lives. Now, there's no study corroborating the connection between the fact that somebody who is seriously sick and why they would choose to end their lives. But I think a little application of mind would make it quite clear. And one of the reasons is that in a country like India, 55 million Indians are pushed below the poverty line because of catastrophic out-of-pocket health expenditure every year, of which 38 million people are pushed into poverty because of the cost of medicine. And this could very well be one of the major reasons why people choose to end their lives, because of the financial toxicity that serious illness brings. And so why palliative care, and why are we talking about advocating for palliative care to be integrated with the larger healthcare system? So typically, this is how a lot of people perceive palliative care, end of life care. And that may be true in certain contexts. And of course, certainly palliative care does include end-of-life care. But in our context, it is so much more. Palliative care includes the community. Pain relief and symptom management is just one element. A lot of emphasis is placed on the skill and capacity of the interdisciplinary team, from doctors, nurses, social workers, occupational therapists. Psychosocial and spiritual care and sustenance is as important. And of course, we have death preparedness, support for the family and the caregiver, and a deep sense of dignity to be restored to the patient and the family. And overarching all of this is empathetic communication. I saw in the chat some questions about, I think, which would be covered in our communications module. So, but empathetic communication, which is clear, competent, and comprehensive, is so essential to good service delivery of palliative care. Now, Dr. Roop Gursahani is a leading neurologist in India. He's also one of the founding members of the End-of-Life Care Task Force. And he's also one of the strongest champions for advanced care planning. And he said this once, he said, modern hospitals are like fortresses. The poor can't get in and the rich can't get out. And I don't know what if this rings true for Bhutan as well. And somewhere along the line, we started referring to it as the healthcare industry. It's been a subtle but profound shift from the healthcare service. And this really speaks to the corporate capture of, an industry presence in healthcare. And this is where palliative care becomes important. Now, one of the groups that are quite marginalized in India are the affluent, because they're likely to go into a high-tech private hospital where there is no palliative care team. And they will probably get futile and unnecessary interventions, life support, especially when they're in advanced stages of an illness. And at that point, it becomes very difficult for them to even be around family, and they usually die alone in ICUs. And this is really, the Lancet Commission on the Value of Death speaks about this over-medicalized technocratic death that certainly the Western countries, but also communities of affluence experience in low and middle income countries. And this is where palliative care comes in. And this is the kind of model that we have, the community-based palliative care model, where the community bridges the gap between the individual and the healthcare system. And how do we do this? Meeting people where they are when they need it is actually derived from the Astana Declaration for Universal Health Coverage. And I'll come to how we actually logistically manage this. But before I do that, I just want to talk to you a little bit about total pain. This is a concept that we believe in palliative care. And what this really talks about is the fact that when someone reports their subjective pain on the pain scale, 1 to 10, 10 being the highest, most excruciating pain, and 1 being minimal, we have to remember that the physical pain that they report is compounded by their life circumstances. What do I mean by this? Let's do a quick thought experiment, shall we? It's a Sunday morning. You've woken up, you have a bit of a headache. It's not like a migraine or anything. It's just a headache, maybe because you're dehydrated or you haven't slept very well. And you have someone at home who can, make you a cup of tea or soup. There's someone to massage your forehead. You can get back into bed and maybe just rest it out. So that kind of a headache, where would you score it on the pain scale, 1 to 10? You can use the chat box. 1 to 10. Sunday morning, you have people to take care of you, pamper you. You have, you're able to rest. 3, 2, 2. Okay, I can see that it's all veering towards the lower part of the scale. Same headache. Monday morning, you have a flat tire. Your child has woken up and thrown up his breakfast. You have a deadline that you haven't met. You've got 3 calls from your boss asking you where on earth you are. And, on your way to work, you meet with a little bit of an accident that delays you even further. Same headache, score it now, 1 to 10. 6, 10, 9. Okay. See, nothing. Your life circumstances have changed. And I want you, well, Karvi, I'm trying to 3 for you. But this is what subjective and total pain is. Your pain is determined by your life circumstances. So imagine a person living with cancer, what they have to contend with, what their pain must feel like. They've had to mortgage their house to pay for their chemotherapy. Their child has dropped out of school because they can't afford the tuition anymore. The caregiver has given up their job to stay at home. So that pain, can you imagine what that pain feels like? So this is just a trivial little thought experiment I did with you, but I'd like you to apply this to your patients and families when you think about what their pain level is. And total pain also takes into consideration these 4 quadrants: physical, psychological, socioeconomic, spiritual. How has this illness impacted me on these 4 domains? And if I am to bring down that pain scale score from 10 to 1, I need to take care of all these different quadrants. And so that is where the interdisciplinary team becomes very, very important. And this is where I personally believe that palliative care becomes a social intervention, not just a healthcare and a medical intervention. Okay, so some of the ways in which we address total pain. What you're seeing here is a picture of a primary school in a little village outside Trivandrum, where we are located. And we have this system where we develop link centers in the villages outside Trivandrum. And a link center is basically any public place. It could be a primary school like in this picture, it could be a library, it could be a community center where the community can gather. And we train volunteers in the community to be able to identify if somebody in their community would benefit from palliative care. So we actually teach them about the myths, and we say it's not just for terminally ill cancer patients. It could be someone who's bedbound, it could be someone who's elderly and frail. And if you feel that they would benefit from palliative care, please inform the link center, and the link center then lets our home care team know. So the people who come to the link center to collect medicine or to get a consultation are usually the people who are well enough to come there, right? But there are those who are so unwell that they can't even come to the link center, and that's when our home care teams go to them. And very often the roads are not motorable, and we have to park the home care van far away and walk quite a distance. And if we have to walk so much, you can imagine what it takes for a patient to make it to a hospital setting. This is a little, let me describe what's going on here. So this boy here, he's about 22 in this picture. When he was 19, he was in a road accident, and he had extensive injuries to his spine, to his head, and he was in hospital. And then he was told that he needs physiotherapy once a week. Pretty simple, huh? Once a week, physiotherapy. But here's a catch. He lived alone with his mother, a single parent. She needed to work in the plantations the whole day to make enough money to feed them. Their house had several steps. He couldn't walk, and he's a big made guy. And the house itself was on top of a hill. To get to the main road, they had to come down the hill, go up another hill, come down that hill, walk another kilometer to the main road where there was no bus stop. And she would then have to hire an auto rickshaw to take them to the hospital, wait till the physiotherapy is done, and come back 14 kilometers. And that would cost her a week's wages. So this boy wasn't going to get any physiotherapy. Now, does he qualify for palliative care? In our books, he does. And his link center actually led us to him, and our team started visiting him every day. And we did this little bit of reverse innovation where we set up parallel bars in his home. And after a while, he was able to use them by himself. And today, I'm very pleased to tell you that this boy is mobile. He's back on his feet. He's re-engaged with the workforce, because earlier, if he needed to go to the hospital, 4 men from the village needed to take time off work, carry him on a stretcher to the main road. And anyway, so now he's back, and he was also very depressed. And I'm also happy to tell you that he's come out of that depression too. So this is the beauty of palliative care and home service. And there's no point giving people free medication if they're starving. So if 55 million Indians are pushed below the poverty line every year because of out-of-pocket healthcare expenditure, that means they don't have 3 square meals. And so part of the palliative care service is to provide them with dry rations and monthly rations. And about 100 families get these monthly rations from us. So in our books, this is palliative care too. So this is a volunteer from the link center. This is our nurse. And we're just, going from one house to the other to deliver the dry rations as well as the medicine. Very often, this is the terrain that we have to traverse. And this is on a good day in Kerala when it's not raining. So when it's raining, it makes it a little bit more complicated. But also, I want to take this moment to tell you that, to me, this picture symbolizes something else, which is very important, that something can be available but not accessible. There is the availability of a healthcare system, but it is not accessible to a lot of people. So it's not enough that we advocate for availability. We have to advocate for accessibility to people from different strata. And a huge, the economic impact of a serious illness. If it's the breadwinner who's fallen sick, then obviously the whole family also suffers that much. Like I said, the caregiver will often, drop out of the workforce to be able to take care of the person. This has a huge impact on dignity and the spiritual well-being of the family as well. So one of the things we do is vocational rehabilitation for the caregiver as well as for the patient, so that they're able to earn an income even while they're at home. So here you see a patient who has paraplegia. He's making umbrellas, and that's something that's always going to be in business in Kerala. We have a caregiver who's become a seamstress, and she runs a little shop from her house, so she's able to take care of her child with cerebral palsy, at the same time earn a living, and that to us is also palliative care. One of the major something that actually suffers collateral damage is the education of children, because when treatment costs are so high, often children will be taken out of school and that money is reallocated to treatment. And so you have the illness of one person in one generation actually impacting the future of the family, and children lose out on opportunities, on education, and then they have that huge setback. So at the moment, we have supported over 500 children with the educational needs, children from disease-ravaged families, to make sure that the illness of the parent or an elder in the family does not derail their entire life. And I'm very happy to tell you that many of these children have chosen medicine as a field of study, so paying it forward. Just to pivot a little bit, zooming out, I'm not sure if Odette covered this because I missed the first few minutes, but it's estimated that about 68 million people experience serious illness-related suffering globally, of which 51 million are in low and middle income countries like ours, of which in India, we have 7 to 10 million. And for over 80% of the global population, there is no access to pain relief or palliative care. And I just want to spend a little bit of time on the international treaties that govern access to medicine, especially opioids and morphine and narcotics. In the international treaties, the drug control treaties, there is something called the principle of balance, which basically says that while we prevent the misuse and diversion of controlled substances, we have to make sure that they're also available for medical and scientific purposes. These are governed by international laws of criminal justice. These are governed by international laws of human rights. And ideally, the public health system is balanced by these two being, balanced against one another. Unfortunately, the focus is on prevention and diversion and control and regulation. And this has also stemmed from the war on drugs rhetoric that came out of America in the 60s, 70s, and 80s. And it has had a disastrous impact on the rest of the world. And here, there's a saying that I love: if you don't have a seat at the table, you're probably on the menu. And this is true for a lot of us, because if we are not at the decision-making table, then the policies and legislations that are being framed, the guidelines that are being framed, are not inclusive of what our contexts are. Even today, all decisions about health and medicine are made in Vienna and Geneva, where a lot of countries don't even have, a diplomatic mission to. And a lot of the policies are framed through a global north lens, which is not entirely appropriate to our setting. So it's very important for us to really participate in this ongoing conversation. We might have our small little practices in our own silos, but we need to understand that the larger ecosystem does frame our own clinical practice. And a colleague of mine from Rwanda once told me that if you don't have a seat at the table, bring your own chair. So that's something that we should all strive to do. Now, what happens when you don't have adequate representation? Odette talked about the access abyss that the Lancet Commission of 2017, mentioned in their report. And this is the signature illustration from the Lancet Commission of 2017 on pain relief and palliative care. Now, this is an atlas of the world, and it's skewed, because this is an atlas of the world based on the estimated percentage of needs met in terms of pain relief analgesics and the morphine equivalence consumption worldwide. So we all know about the North American opioid crisis that tends to dominate the news. But what we're missing is a larger crisis across the rest of the world where there is a lack of access. And a lot of the time, this problem gets stated saying that we don't want to have another opioid crisis. We know enough today to know where that crisis originated. Now, Western Europe has struck some sort of balance, but if you look at the rest of the world, countries have just disappeared off the map. And if you look closely, a lot of them are erstwhile colonies. So history has had a huge impact on the way we are able to access medicine today. And in India, this resulted in the Narcotic Drugs and Psychotropic Substances Act of 1985. And when it came in, the morphine consumption went from 716 kilograms a year to just 18 kilograms by 1997, which means that the pain burden in the country rose that much. And it took 19 years of advocacy by civil society to finally have this law amended. It took us 19 years. Very often close to giving up, but finally we amended the law. It's a lot more, it makes provision for better access now, although we have a long way to go. But a large part of the work that we do is still advocating with the authorities to make sure that access to medicine remains on the agenda. I just want to share with you, this is important. It's really important for us to also generate evidence from our own context, because at the moment, 93.5% of research publications comes from just 15% of the population. And that is what that's what guides a lot of the, not just best practice, clinical practice and policy and legislation as well. So it's very important for us to generate research and create evidence from our own settings. And really, for access to pain relief and palliative care to work, we need policy, education, and demand from the community to really click into place together. And not just that, this conversation needs to span all of these different stakeholders, the public, policymakers, professionals, private sector, at the local, national, and international level, because that's how we change the perception of palliative care to not just the lay people, but also to the medical fraternity, which very often is quite resistant to palliative care for whatever reasons. And finally, I'll say that just like we have the principle of balance for access to, for the drug control treaties, it's very important for us to remember that we have to strike a balance also in our perception of where palliative care and substance use disorders clash, because, this idea that the opioid crisis on one hand and the lack of access on the other, this debate has always followed this sort of logic of control versus access, harm versus value, restriction versus enabling. But where we strike the balance is a patient-centric approach. Always focus on the patient, and let that be your guide. And we have to focus on the suffering of the individual and the family, whether it's a substance use disorder or whether it's someone with palliative care needs. We have to focus on safe access, not just improved access, through high quality data on opioid use outcomes. And that's where our research becomes important. And finally, we can't do it alone. The government, as well as professionals like us and civil society, have to all work together to make this happen. Wherever the models of care have worked best are where these three players have come together to really work together. I've talked about data and maps and statistics, but this is what it really comes down to. Every human story. So this man, we found him in this position. For 3 weeks, he'd been doubled over in pain. He couldn't do anything else. He couldn't think, he couldn't eat. And just 3 rupees, which is less than 5 cents worth of immediate release oral morphine, allowed him to sit up and have a cup of tea for the first time in 3 weeks. This is what we want for everybody. This is the quality of life, the improvement to quality of life that we want. And it is within our power to do it, but we have to be able to advocate for it. I'll just conclude with the personal story. And this is a little bit entwined with my journey in palliative care. I got into palliative care in the year 2000 when my adoptive mom, my mother's sister, she adopted me. She died of cancer in 2000. She died under excruciating circumstances. We were relieved when she died because it was just a nightmare for all of us. Nobody told us about palliative care. By 2003, I had lost my father, my grandmother, a couple of aunts, all to, various, one to COPD, two to cancer, one to a stroke. And around that time is when Pallium India was also founded, completely different from my story. I went abroad to study at St. Christopher's. I came back, didn't really know how to apply it. I hadn't really met the, other palliative care people in the country. And then, of course, I discovered Dr. Raj and Pallium India. And over the next few years, many important milestones were achieved in our country. Palliative care was recognized as a subspecialty. It became part of the Indian national program. I mean, we had a national program for palliative care. The Narcotic Drugs Act was amended. Palliative care was included in the national policy. And of course, it was introduced finally in the undergraduate medical curriculum as well as the nursing curriculum over the next 3 years. Great progress in just about a quarter of a century. Last year, I lost my mother to idiopathic interstitial lung disease, and it's a disease that leaves you very breathless. And what we needed as part of her care at home was immediate release oral morphine. I had to jump through hoops and hoops and hoops to get it. And I work with one of the premier palliative care organizations in the country. So while all of this progress took place, on the ground reality is very different. I cannot even imagine people who do not have my connections and my access to, and knowledge of the law to be able to access medicine for their loved ones at home. But because of my training, I was able to care for her at home, give her a dignified death at home. Otherwise, for most people in her condition, she would have been whisked away to a hospital, she would have been resuscitated, she would have been intubated, and she would have died in an ICU. And that remains the reality for most of us. So a lot of work still to be done. And I'll just close by saying that a good health system delivers quality services to all people when and where they need them. And I will also add, at an affordable cost. And that is something that palliative care is actually able to do beautifully, which is why it has to be integrated into our health system, because it really takes the burden of an otherwise already overburdened healthcare system. Tara, if I may share a quick video, please, if that's all right. It's from the African Palliative Care Association. It's one of the most beautiful videos. And I think it really sort of encapsulates, everything that we aspire for palliative care to look like in a low and middle income country. So this is by the African Palliative Care Association. I'll stop with that, Tara.
Progress.
Thank you very much, Smriti. I'm so glad that the introduction session was so comprehensive, and I'm sure our participants have really got a good grasp of what palliative care is. And since we just have 4 minutes left, there were a few questions that I tried to answer with the chat, using the chat function. And there was especially, I think, one participant was concerned about should we be revealing the diagnosis to the patient? And she mentioned that we normally do not do because the patients do not want. So if Odette or Smriti would quickly touch on it, how important it is to reveal or not to reveal and how you normally do it.
Smriti, do you want to answer that, or shall we both try and answer that a little bit?
Let's both try. You go first, Odette.
I'll just briefly say, I think there's been a lot of emphasis on disclosure as almost a must, and that comes from the respect that we have for patients being able to have some autonomy and control about their treatment. And without knowing what they're being treated for, it's often difficult for them to have any say. But we also, I think, need to be very careful about the cultural dimensions and finding ways to engage patients in their decision making and help them to understand what's happening in a way that's very culturally sensitive. So if it means talking with the family first, and engaging the family's trust in order to then include the patient in the discussion, then I think that's very appropriate. And disclosure should never be in such a way that leaves the patient feeling completely hopeless and abandoned. It's not the disclosure that's so much important, it's allowing them the capacity for some decision making in their own care. Smriti, do you want to comment further on that?
Yeah, I'll add one more point. I think it's also important for us to remember that in some of our contexts, the idea of autonomy does not quite work in the way that it's in the textbooks. Because I know that in India, we, rather than individual autonomy, we look at relational autonomy, where we rely on our families to make decisions. Now, unhealthily, sometimes that will become collusion, where they say, don't tell them the truth, etc. And I find that in my practice, the reason why a family will gatekeep like that has more to do with their own fears. And I think it really makes a difference if you can sit with the family and say, tell me what you're afraid of, rather than saying what the patient is afraid of. Tell me about your fears. What do you think will happen if the patient were to be told this? And that's the first level of gatekeeping that you have to go past. And that will actually reveal a lot to you in terms of family dynamics, who makes the decisions, why. And also remember that very often it's the person who controls the finances that makes the ultimate decisions. And that person may be in a different country, not by the bedside. So before we jump into deciding whether telling the patient the truth is good or bad or needed or not needed, I think understanding the family dynamic is important. And I would also say that there are some patients who absolutely, definitively don't want to know. And we have to respect it. We have to respect it. We cannot impose our, ideas on them at that point, because for whatever reasons, even in spite of, knowing that they might be able to make other decisions if they knew the diagnosis. And with others, they let you take 5 steps forward, 2 steps back. And so you have to do that dance also. So there's no one size fits all. You really have to feel your way through it.
Yeah, thank you. Just to compliment, add on it. Just a practical example that last year I lost my mother-in-law to an advanced cancer. And it was a blessing that I had just completed my studies, having studied palliative care. And it was overwhelming initially, but down the line, as I cared for her, I could prepare the family and the patient. Because my mother-in-law wanted to know her diagnosis, we could empathically reveal to her. And it was hard initially, but later on we realized that it actually helped her and helped all of us, including the family members. And I have a neighbor who lost a loved one to a similar cancer, and we were talking about it. And my neighbor said, our patient wanted to know, but we never told her. We could never tell her. And he regretted for not being able to tell her today. So it all depends upon how we talk with the family, understand what their fears are, as Smriti mentioned, and respect what their culture is, what their understanding is, and help them to do the best for the patient and for themselves. That's what I would also say. And with that, we came to 5 p.m., 5:01, and I wanted to share about my research, but I thought I will share my research in the chat, in the WhatsApp group, so that all the participants may be interested to read. And since we do not have more time, I would like to really, really thank Odette and Smriti and everyone for being here. And if you have burning questions, dear participants, please put it up in the WhatsApp group. We can still try to answer your questions and help you understand more on palliative care. And with that, thank you very much, everyone.
Thank you.
For this wonderful first session.
Thank you, Dr. Odette. Thank you, Smriti ma'am. Thank you, Tara Devi, for facilitating the sessions. Thank you all for joining and participating. Thank you. Let's see you in the next session. Bye.
Thank you, Sangeet.
Take care. Bye.
Bye-bye.